Just one small aside in the middle of that. I mean, the e-education debate has moved on a bit. I remember the days where it was all about how could you expect teachers to learn the technology to teach with, and in the middle of that, Kate said, how can you expect teachers who are used to the technology to teach without it? That's a bit of a shift over the last few years, I think, Kate. Then next up is actually Richard, because he's mic'd up. Welcome, please, Richard Medlicott. Thank you.
I must say it's refreshing to come to a health information, not to health information technology, but rather to an information technology conference. It's the same place, we often come, it's the same food, very different faces. It's less intimidating than it was when I arrived at about 12 o'clock today, because the room is pretty empty, another advantage of being one of the last speakers. It also gives me the opportunity to talk about doctor-patient killer apps without the audience feeling that they're a really bad thing, but hopefully you could see that they're probably quite a good thing. But a little bit of context. A colleague of mine gave me this yesterday. You probably can't see it, I'm sure you can't, but it's the Wall Street Journal. God knows what she was doing with the Wall Street Journal, I do not know. But anyway, there's this article, 2 pages, is headed, "Should Physicians Use Email to Communicate with Patients?" So welcome to the brave world of 1996. This is essentially where a lot of health is at the moment, notwithstanding the invitation for well-remunerated GPs in Australia to clip the ticket for a 5-minute video consultation paid for by the government. My God, they've got it good over there, because that ain't going to happen here. We've got some very, very different models. So what are our models? One of the briefs here was to talk about the drivers for the uptake of broadband in health. And what kind of driver do we want? Are we going to have driving Miss Daisy, slow, calm, thoughtful, safe, but will you ever get there? Or are we going to have a more New Zealand model, perhaps Smash Palace, or Goodbye Pork Pie, and we know how that ended, which was a wild ride and felt good at the time, but left us with feeling naked and with headaches. But anyway, I'll talk about a little bit what's happening at the moment. There's certainly the use of broadband currently in the health system, and I'm talking about broadband, high speed, lots of data, as opposed to telehealth. We've heard a lot about telehealth, and in fact there's a conference tomorrow at the Tamaki on telehealth as well, if you want to go along, a HINS conference. Telehealth doesn't necessarily need broadband. Video needs broadband. So there are some initiatives on the West Coast in particular where doctors and patients are having remote clinics and using expertise in Christchurch for patients on the West Coast, and that addresses a very key driver, which is workforce problems and low numbers of experts out there when expert advice is needed. The other thing that broadband and video can deliver is multidisciplinary team meetings. I was talking with a surgeon who works in the hut last week, who's a cancer control surgeon. For cancer, it's very much a team process with the patient at the centre, but with radio-oncologists, nurses, surgeons, radiation therapists, radiologists, pathologists, all having to plan the care for this patient. Now, it's much easier for this surgeon who's got a busy schedule at the heart hospital to go in on video conference and have a team meeting with many of them attending via video at Wellington rather than having to drive in. So clearly there's a small little pockets that are happening out there. Other ones are radiology, where radiology images can be reviewed in great detail by remote radiologists, which raises interesting questions around governance and registration. The situations that arise where a New Zealand registered radiologist might be doing reports for patients who are outside New Zealand and vice versa, and certainly the Medical Council is working on these issues at the moment. But anyway, that's some secondary care stuff. I'm a general practitioner for my 9-to-5 job, and for me the killer patient app has got to be video consultation. But where is the driver for that? I communicate quite a bit with my patients through a patient portal, with secure email. They can book online, they can ask me questions online, and I'll reply. no one has yet said, hey, Richard, would you like to use Skype? And as yet, I haven't said, hey, whoever you are, do you want to use Skype as well? I think there's a role for that. I work in Wellington. I've already got broadband. The patients I serve have busy jobs. It costs them time and money to come and see me. God knows there's no public service left. They're all on contract, which means they earn an hourly rate rather than a salary, so it costs them a lot of money to come and see me. I know because my wife is one, and she earns much more as a contractor than she ever did as a civil servant. So it's expensive for people to come out and see me, not just the $40 that it costs. So I would say to Ernie, who we've talked about this before, that $25 ain't going to cut the mustard. For convenience, they need to be paying me $60, $70. And there you get the inverse care law in terms of remote medicine for non-connected rural communities. The costs are important. Costs including $5,000 for a telehealth device. That's 25 years of general practice funding for that patient. So anyway, the cup has been tapped. I shall take my leave and be interested in any questions down the line.